some apologies which we have already noted today. Jeff Farrar, the chair, sent his apologies. He's on the interview panel for the chair of AWP, which is a really important post for us in this system, and we wish him well, and I'm chairing in his place. We've got apologies from Stephen Peacock, and it's great to have Hugh with us today. We've got apologies from Dominic Hardesty, Rob Hayday, John Hayes, and we've got welcoming Steve from North Bristol Trust with Maria Kane's apologies. Are there any additional apologies, Lucy, that we need to take? No. And I know that Mark is with us, but he had to go out, and he'll come back when he can. So welcome everyone. Are there any declarations of interest on anything on today's agenda? No, we'll take those as noted in the report, and we'll go to the minutes of the March meeting. If we can take them in their entirety about accuracy. Any comments on accuracy from anyone? No, so we'll take those as a matter of accurate record, which is brilliant. And we've got 2 recommend closure actions on the action log, so I suggest we don't go into those. Are there any other actions people identified that we haven't picked up? No, great, good. That's nice and simple. So, Shane, over to you for Chief Executive's report, please.
Thank you very much, Chair. And colleagues, as always, have 3 big things that are at the front of my mind today. I just want to talk about where we are with organisational structures, general practice risk, and then obviously the future locality partnerships. I'm not going to read the paper verbatim, obviously, but in terms of the organisational structures, colleagues will be very well aware we started a process a year ago at the May 23 board meeting, and that process was about reorganising the organisation, that is the ICB, to look at the reduction in running costs, but actually we use it as an opportunity to look at actually what's the role and function of an ICB. Just raising to the board today, we have now concluded the reorganisation process. We have been in the position of the last small number of recruitment activities have been completed. And as a result now we're in a position where we have the ICB, we have the staff, we have the organisation we need. And what we're beginning to move forward now is a launch of what actually is the role, function and what this organisation will do over the coming years. And you'll see in my report, we're talking about a really important event on the 15th of May, where all staff from the ICB are coming together. And we're looking at the new operating model, but we're also looking at what is it this organisation is going to achieve. And I've referred to in the document the bounce. We're talking about the bounce. How do we get energy in the organisation to bounce forward into the challenges that we have? So, as I say, I think it's important to, I'm going to draw a line under this in the Chief Executive's report now. The Shaping Our Future process is over, and what we're now into is delivering the new organisation. I think just to have it on record, Chair, this has not been an easy process for the organisation to go through. Many of our teams, many of our staff have been very uncertain of their future. We're now at a place where we've stabilised the organisation and we're about to bounce forward into the new world. Second area then, Chair, I think is really important, is to raise to the board a letter received from the Chair of the GP Committee, the BMA, and I've copied it word for word into my report today, which really highlights very clearly the notification that the real chance of some forms of industrial action within GPs. I think it is really important that the letter is there so you can see the very valid challenges and concerns that the GP family have with where they are, and clearly what the letter is saying is we're giving you due notice, but you really need to consider what it is as a system, what it is as an ICB we are going to put in place to keep patients safe should industrial action be taken by GPs. And it's a really, I think it's a really important letter. And really what we're now starting to do through Dave's office, and also through the primary care committee as well, actually, Chair, is begin to understand, okay, what is our mitigation? What are our mitigative actions? You know, so we've obviously as a system dealt with industrial action quite a lot in the last year through junior doctors and consultants, etc. So what learning can come from that. But actually it is different. It is very different. We're talking about 1.4 million appointments. We're talking about the front door of the health service. And we are now starting to build what is the mitigations that we could put in place to keep patients safe should GPs go this particular direction. And I'm not making any judgment as to any of it, but I think we must put mitigations in place because I think that this is a real danger, not something theoretical on a piece of paper. Okay, Chair. So we're working on that. And the final part of my report just reflects on the future locality partnerships. We got a lot of energy around the reorganisation of the ICB, particularly locality partnerships. I brought to this board that we'd be exploring with the ICP a review of locality partnerships. I have included in the document the draft agreed objectives of the review of the localities, and the reason why I say it's draft, it's still going back and forth, so people are still giving comment on it, but it gives an understanding of what we're trying to do. We brought it to the ICP last week, 2 weeks ago now, just initially for their view. Ultimately, this is an ICP commissioned review, but what I think is really important to stress is that there's a series of channels we need to go through. Health and Wellbeing Boards, the ICB Board, so much more before ultimately the ICP can say, yes, this is the right thing to do for our locality. So although ultimately the ICP are commissioning it, there are steps in the system because we've got to make sure that as a whole system we are content with this before the ICP could then say, yes, this is the right thing to do. So as I say, Chair, 3 big areas. Happy to take thoughts, comments or questions.
Thank you very much, Shane. And just in relation to the possible industrial action, we had it was going to be one of my items on update from Primary Care Committee. We had a really good discussion on the issues, the potential issues that might come up, and Dave and his team were starting to look at the emerging risk profile, and I think there is some experience of looking at industrial, although this is quite different. It's completely different, but there is a principle there. But I think we will keep a very close eye on that at committee. So thank you very much for that. Any comments, questions to Shane on his report? Ellen.
Thanks, Shane. So just first of all, can I just put on record, just to recognise the hard work that's gone into shaping the future. The way in which it's been conducted, really sort of probably the highest class I've seen, and the engagement sessions that have been led by the directors I thought was phenomenal. So I just wanted to put that on record. And in terms of locality partnerships, just wanted to understand what the position was in the short term. So this piece of work will obviously be going on. What provision do we have over the coming months? Yeah,
so the locality partnerships themselves are still existing and running in the way they've always existed and run. We have made our operational changes whereby there used to be 6 locality leads. We now have 3 locality directors. Those appointments were concluded, I think, last Tuesday, David?
Yeah, correct. Communication went out.
So communication went out about the new locality directors so that they still function and function in the way that they're intended to function. This review is asking where to next. So how do we really make it the real vehicle for change, and therefore it's where to next, but the stability of them is clear.
Thanks very much, Ellen. Stuart, thank you.
I'll just flag up, if I can, that it's important to remember that the trainee doctors' industrial dispute remains unresolved, and at the same time this week the BMA have announced that the SAS doctors' dispute is unresolved, and that they've issued an equivalent type of warning in terms of you need to start thinking about preparing yourself for industrial action in the SAS group. Now, of course, there's also a bit of history here of aligning industrial action across those across different groups of professionals taking action. And I suppose in terms of the mitigations and planning you're considering for primary care, I think it'd be quite important to ensure that that's aligned with secondary care in terms of if there is the risk of either sequential action or contemporaneous action across those different groups.
Thank you, Stuart. I think quite clearly through Dave and the emergency plan EPRR world, absolutely it's a plan for industrial action, which is not exclusive to any single group. So you're actually correct. And you are right. I mean, we do know industrial action is placed often to create the biggest impact, and therefore, you know, it might not be unexpected as if that impact was not a single impact.
Dave,
Dave.
yes.
Stuart, thank you for flagging that. That really mustn't go unnoticed. Yeah, these other disputes aren't concluded yet. I will just add Alison to the Primary Care Committee discussion, which the value of having non-executives from other organisations there. They're all brought in the really significant, not unintended, but the consequences on Sirona, on acute services will be significant. So we have to take all the learning from the previous approaches and really work with partners in planning for any potential. But the value of understanding those consequences was really helpful at Primary Care Committee.
Yeah, thank you, Dave. That's a really good point. I think we've been incredibly lucky with the non-executive presence at PwC, both from North Bristol Trust and from Sirona. So thank you to colleagues. Great. Any other? Shane, thank you very much indeed. Let's go on to the two substantive items. These are really important items, and it's really good that we've got some time to go through them. And the first one is LMNS, which you might want to say out in full, Rosie, and also introduce any guests we've got. But over to you for this section.
Thank you, Chair. The colleagues will remember we have agreed at board that we have a 6-monthly update around our maternity services. So our local maternity and neonatology system is a partnership piece of work across the Acute Provider Trust, Sirona, Care and Health, local authorities around making sure we have the very best quality of care for our mothers and our children through the maternity journey. And as board are well aware, there have been some real difficulties in maternity systems elsewhere in the country. So we work very hard as a partnership to make sure we have the very highest standards of care that we can for our families. So what we agreed is board would hear an update from the LMNS on a 6-monthly basis. We had Layla come and talk to us about 6 months ago, and she's here again, and she's got some great news for us. So I will hand over and let her share some really positive news.
Thank you, Rosie, and good afternoon, everyone. I'm Layla. I'm the Patient Safety Lead for Maternity and Neonatology within the ICB and lead on the LMNS work within BNSSG. So, as Rosie said, some of you will remember at the beginning of last year, I presented to board that there was quite a change in the direction of strategy that was coming down from NHS England for maternity services, and quite a lot of anxiety for maternity as to how we would perform with a lot of new guidance, a lot of new documents, CQC inspections on the way. And I'm here today to, as Rosie said, give you the good news of where we are within BNSSG with our maternity services and the huge amount of positive work that has happened over the last year. So I'm not going to go through the whole paper, I'm just going to pick out some key points. But the big one is the CQC inspection. So both of our acute maternity units were inspected last year in October and December. Both CQC reports have now been published and are in the public domain, and both of our maternity services maintained their good rating, which is really pertinent in the national kind of where we are nationally, as 75% of maternity services in the UK have been downgraded. So it really is a massive achievement. And in addition to that, North Bristol Trust's safety rating went from requires improvement to good, and that is one of only 5 maternity services in England to have achieved this improvement. So I think it's something that we really should be proud about, and we should be informing our women and birthing people within BNSSG. The other thing that I wanted to talk to you about was Saving Babies' Lives version 3. So again, anyone that heard my last update is a piece of national guidance that is in line with the national ambition of reducing our rates of stillbirth, neonatal death and brain injury. Saving Babies' Lives has been around since 2016, but the new version got released last year. And it actually came quite late in the year. We didn't actually get it until May. So we had a bit of a challenge to reach the compliance target that was required by NHS England of 70% by the end of the financial year last year. And both of our trusts achieved over 80% towards this compliance and are making really good progress to be above that this year. So the work for 24-25 will be continuing to work with the trusts to get our compliance close to the 100% standard, which will be absolutely amazing. We're not expecting version 4 this year, so it gives us a chance to really embed and continue to work with version 3. Another piece of documentation again that came out last year was the Year 5 Maternity Incentive Scheme. And again, a huge achievement for both of our acute trusts, with both of them achieving all 10 safety actions and being fully compliant with Maternity Incentive Scheme Year 5. Again, I wanted to put it in the national context for you. So nationally, 92 out of 120 trusts were compliant, but in the Southwest, actually only 6 out of our 13 trusts managed to get compliance with this. A big challenge around the incentive scheme was having to achieve the compliance of Saving Babies' Lives. They're interlinked. So the fact that we were working so well towards that made it an easier task for us. But really important, again, that we celebrate that achievement. The Year 6 Maternity Incentive Scheme has just been released last month. And they've actually released an implementation tool to support the trust with making sure that the evidence that we submit for that is equitable. And it will really support the LM&S being able to review that evidence and make sure that what is being submitted is of good quality. So that is where we are with that. And then lastly, I just wanted to talk to you about the Race and Health Observatory Learning and Action Network. Which is something that I'm really proud to say that we have been chosen as a system to be part of this network. We're one of only 9 systems in the whole of the UK to be selected, so it's a really big achievement. And the aim of the project is to reduce health inequalities and improve outcomes for our Black and Asian mums and babies. It's a 15-month project that we're being supported with. And within BNSSG, we've made the decision to focus on preterm births and looking at the disparity of antenatal interventions between our white and our ethnic minority populations. So it's a really exciting piece of work, and when I come back in 6 months, I'd like to update you on where we are with that. And the other thing that has just happened is the LM&S has just published our local equity and equality action plan on the ICB website, which sets out all our key priorities in reducing health inequalities for our mums and babies within BNSSG. So a lot has happened this year. Our priorities for next year are to continue to work towards the objectives within the 3-year delivery plan and continue the assurance and oversight of MIS Year 6 and Saving Babies' Lives, and hopefully we'll have the same successes as this year. We're going to continue to make progress with the commitments within the Equity and Equality Action Plan. We're also really working closely at the moment with our higher education institutes and wider South West colleagues to support the development of midwifery apprenticeships. And we also want to lead on producing a local quality dashboard that will bring together intelligence from both trusts and really help us identify where our inequalities continue to be. Thank you everyone for listening, and happy to take any questions.
I'd just like to add one more bit of great stuff, and that is we're working closely with Innovation West of England, what used to be the HSN, on Black Maternity Matters, working very closely with the what was the HSN and Black Mothers Matters around training and education programmes to improve cultural competence inside the wider maternity and neonatology workforce. It's a fabulous programme. We're kind of, again, leading the way in that. I would love to be able to bring it back to a seminar session quite soon. We're doing the evaluation work now. It's being really well received. Great piece of work in collaboration. So I think that's something else just to celebrate in a seminar session. And Layla would love to bring Black Mothers Matter with us to present that to you.
Thank you very much, Layla. Thank you, Rosie. open up to questions, comments. Jaya and then John.
Firstly, well done. Really pleased and pass on so many congratulations for maintaining the standard in very, very challenging circumstances. We're all very proud of you, and just wanted that to go on record. My question, I guess, is to do with knowing about the pipeline of demand maternity services. Anecdotally, I'm guessing that, you know, birth rates are down and all sorts of things are happening. How are we resourced in this respect, and how does that affect the plans going forward into 24-25? You're right, the birth rate is going down nationally, and we've been observing that. I think there is an offset with that around complexity, and an offset for us in our system because we are a tertiary provider around specialist services for both mums and babies with complex needs. We do need to do more work on that, you're right. I think we have very comprehensive dashboards around volumes of activity and the safety measures and the outcome measures, but actually the kind of predictive modelling is something we probably need to build in through our wider population health work. I think just to your first point, and thank you, I think a huge thank you to the Trust, because this is hugely led in collaboration by the two trusts, working really closely together towards a single managed service of maybe acute provider collaboratives. It is a really good exemplar of how we work as a system, I think. Yeah.
Thanks. Thank you very much, Jaya. John and then Chris. Thanks.
Echo the congratulations. Both trusts have done a tremendous job, and it's terrific the assurance that parents can take from this. And I also welcome the focus on midwifery apprenticeships. I think that's a really good thing. I was just interested in the perinatal insights visits and how that gets fed back into our higher education partners, just thinking about CPD and thinking about, say, the maternity apprenticeships. Are universities part of the perinatal insight visits, or do they get the output so that we can continue with that that virtuous kind of learning circle?
That's a really good call, John. I mean, the insight visits were framed from region, and so we kind of had an agreed brief. But actually, what I discussed with regions, I think we need to change that now, because they are a kind of annual cycle. And I think what we agreed locally and in discussion with regional colleagues is about having a rolling programme of visits, so they don't become too formal, and you get much better quality contact with the clinical workforce if it's a more flowing programme. We are going to do some peer review in that, and we've talked to Gloucestershire and BSW again about getting fresh eyes into the system so that we don't kind of get into any kind of fixed mindset. But the higher education bit is a really good call, so thank you, and we'll pick that up.
Yeah. Still know what to come with, but it just seems like a really helpful source of intel. Yeah. Just immediate.
Absolutely, thank you.
Thanks very much, John. Chris, and then Steve. Thank you.
Yeah, thanks for that. Really good report, really well done. There was one sort of gap for me, which was around mental health. And I know that last year, one of the voluntary sector organisations, Bluebell, closed down rather unexpectedly and left a number of people with, or mothers with postnatal depression sort of rather exposed. And I just wondered that one of the outcomes of that piece of work, so doing some work on that, was that that was a particular sort of gap. It sort of fell between two different stools. It fell between the services that were being commissioned through the ICB and those that are commissioned through the AWP. And I know we haven't got anyone from AWP here today, but I just wondered if you could just say a little bit about where mental health fits into this.
I think, sorry, yes, okay. So I think there was a good piece of work to safeguard those women, and there were other services available for them, so they were safeguarded at the time. The perinatal mental health services are a bit of a partnership piece between the two trusts and AWP and other services, and I think there's more work going on now, isn't there, to carry on strengthening that. So I'll let you come in, Lola.
Yeah, thanks, Rosie. Yeah, absolutely. So at the time of Bluebell closing, we did a huge amount of work with our contracts team, our perinatal mental health services, and identified where our other voluntary sector groups could step in and support those women. So Mothers for Mothers have opened up new groups with peer support, so to kind of fill that gap. From a perinatal mental health point of view, our teams are working much closer with AWP. So we've developed some midwives, a specialist team of midwives that work for the MALT team, which is the loss and trauma team that are working really closely with AWP to support our women with perinatal mental health services. But of course, there's a lot more that we can do in that area.
Again, it's the same as earlier, Rosie, just anything that we can
Yeah.
support on that. That's
Thank you, Chris.
Thank you very much, Chris. Steve?
Thank you, and thanks again for the work. I think what I was going to highlight was just that when we collaborate well across our system, we make amazing things happen. And I think the midwifery story, both in terms of working with what was the academic health science networks, but now health innovation networks, with local communities, so users, really delivered something very powerful. And I can think of at least 3 big programmes of work with midwifery services that have put the midwifery services in this part of the country in a really strong position, because lots of the research sponsored through the Academic Health Science Network with communities has actually led to 3 national programmes being adopted, and that's something that we should be really proud of. So the teams are working well together with local communities, and we're drawing on the expertise from across the region to make sure that we, in effect, improve the services and create opportunities within that. So really well done. It's fantastic to see.
Thank you very much, Steve. Aisha?
So thank you. I appreciate it's early days, but I was wondering if you had any thoughts on how you'll sustain the interventions as part of the RHO Learning and Action Network after 15 months.
Thank you. So this is something that we've given a lot of thought to, and we've realised very quickly that 15 months is a really short amount of time, and that actually when we've looked at our logic modules for the project, to really be able to see any long-term outcomes is going to take a lot longer than 15 months. So we've made a commitment that the core team that are within the RHO project will continue to do this long after the 15 months. So it's a supportive programme with the RHO. It's not funded. So all of the clinicians that are taking part in the programme are doing it in addition to their other roles, and everyone has made a commitment to carry on. So I think we've realised that within 15 months we will have possibly some short-term outcome measures that we can discuss, but we know that the project will continue long after that, because 15 months is not long.
And I would have also thought that we then take the methodology for this and look at other areas where we think we should improve performance and outcomes and repeat the cycle. So we want this tranche of people to go through, become experts in the methodology, and then we'll look at what else we need to improve on and do it again.
And the other thing, sorry, Rosie, just to say, is that the other 9 systems that are focusing on other areas within the disparity, but focusing on things like hemorrhage, diabetes, we come together monthly as an all teams event. So actually we'll also be able to bring back the learning from those other systems and then adopt that within here. So it's not just our project that we'll get the learning from, but all the other systems nationwide. So yeah, it'd be really exciting.
Thank you very much. I just had one question. I wanted to add my congratulations, and I think Stuart and Steve, if you can take comments back directly to your teams as well, because it is about the delivery for individuals, isn't it, as well as the team approach. Really like the idea of being innovative and targeting in areas where we want to improve. In terms of the priorities for next year, and it might be wrapped up within the equity plan, one of the other areas of concern, maybe in this system, but I've seen it in other systems, is where English isn't the first language. Yes. And I just wondered if that is somewhere in the detail of the plan that we're not seeing here, but I think pulling out those areas where we know we really, really want to target some significant improvement, and I guess that's what that plan is for. So
I think that maybe needs to elevate into a wider conversation around support for people who don't have English as a first language. So it should be certainly within maternity services, but I think maybe we need to have a more system conversation about that, because I think we're challenged with that in other areas as well.
Yeah. So is that specific enough to be an action, Rosie? Sorry, I don't want...
No.
Because it feels really important.
Yeah. I'm more than happy to take it away, and I need to work out who will help me with it.
Okay. That's great. Thank you very much. I don't see any other questions or comments. Really good report, Leila. Thank you very much for everything you're doing. You're asking us to note the report, risks, mitigations and responsibilities. I think it'd be really good to have something back here in due course about how things are going. And I know it goes through Ellen's committee as well in terms of the details, so maybe decide which is the best route. But well done to everybody. Thank you very much.
Thank you. And can I request a seminar session on black maternity matters?
You can, now that you've taken an action, yeah. Definitely. Great. Thank you very much. Thanks, Leila. Great. Let's go on to item 6.2, NHS Impact, our system approach. Debs, over to you, and just lead us and get from us what you'd wish from this session.
Perfect. Thanks, Alison. So before I go into the item, I'd just like to introduce my colleague, or actually, I'd like my colleague to introduce herself to you. So, Helen, you want to just...
Good afternoon, everyone. Hi, I'm Helen Gilbert. I'm the Director of Improvement at North Bristol Trust. And I'm 9 years into my improvement journey, at the start of which I had the privilege of working with Virginia Mason for 5 years at Leeds Teaching Hospitals, and have morphed into the different methodologies, but I'm now working with Steve down the other end of the table there in terms of improvement at North Bristol in BNSSG. So yes, really privileged to be here. Thank you.
Thanks, and thanks to Helen for coming along. So Helen is one of our transformation leaders across the system. We've been developing a network, and what we wanted to talk to you about today, obviously in the paper it flags up 3 core areas. So the first one is how we think about improvement. And improvement, I'm just listening to the conversations both this morning and this afternoon, the word improvement and change comes up so many times. It's what cements us together as an ICB board, is our journey to improve. And one of the things that we wanted to flag up is improvement is a science, improvement is a profession, and we need to think about how we make sure we consciously drive up our capability and the way that we do things, and how we embed that into the culture of the way that we work. It's really great when national policy aligns with local ambition, and that's where the NHS Impact approach comes from. So there was a review that was undertaken last year by somebody called Anne Eden, commissioned by NHS England, that looked at the improvement needs across the NHS. And it was the NHS rather than health and care. However, locally we've been engaged as a system, as you would expect. So although NHS Impact stands for improving patient care together, we've decided it stands for improving people's care together, so that we make sure that it aligns across our system. And then the third thing that, so the first thing we wanted to do was to get a mandate, so that we can look at a kind of much more robust proposal for how we implement an approach that will really amplify our capability, capacity and embedding improvement. The second being just to share with you a little bit about NHS Impact and what it's all about. And Helen's going to share some of her experience as a long-standing improvement expert in terms of what some of these things mean. And then the third thing is we've been working through a set of principles, because of course, as Helen's alluded to, there are lots of different methodologies that are out there. And across our system, we have, for example, Serona have adopted QSA, our acutes have adopted patient first. In our local authorities, there aren't necessarily the same approaches, but when you look at the way that people work, some of the ways in which people work are using the same tools. So what we've done as a group of improvement leaders and directors is started to look at, we've got some principles that define the way that we work together, that are our aligning principles for delivering improvement, which are in the paper, which I'll come to in a second. Then you've got the kind of the improvement methodologies that people use, like patient first or QSIT. And then beneath those, there are a whole raft of tools that, again, we share, whether that's something as simple as asking 5 whys or something more complex like Six Sigma, and whether you're a black belt, which my esteemed colleague already is, and how we start to create an efficiency and a culture across our system is what's really, really important. Helen, were there things that you wanted to add in terms of some of the, particularly around the cultural aspects?
So I think for me, in terms of having experienced, I'm going to say 3 different methodologies in 3 different organisations, but all predicated on the same foundations of the importance of it being led by example through leaders, you having a recognised and agreed approach in an organisation, and actually the more important thing is what do we learn as a consequence of doing that stuff, about the culture of our organisations, and what does it mean that we need to respond to in the development of that. And I often think that's it's the poor relation in this process, in terms of we get very focused on implementing a toolkit, training people, and we become very process driven. But actually, what do we do about what we're learning as a consequence of adopting approach in an organisation? And what I would say is, you know, from the, I'm going to say personal bruises, that's the much harder journey to go on, but it's the more important one to go on if we're really genuinely going to, you know, to create a people-centred organisation that's genuinely focused on improving things for its, and I apologise for the language of customer, but I'm conscious of all the different people we've got around the table, so patients, service users, and of course staff, because some of our services, you know, staff are customers of, so that would be my critical summary insight. It's the harder journey to go on, focusing on what you learn about your organisation as a consequence of those things.
Yeah, and through some of our network conversations, which Ruth has been part of, some of the things that have come up have been and this is not a negative, but it was something that was shared by all the improvement leaders, that at points it's really difficult to try and get people to think about the improvement methodology. And Joe, I know as a QI fellow, that's often something you're kind of, can we just make sure that we're doing this right and we're doing it the right way? It's actually really important that, as Helen said, we as a group of leaders start to advocate that approach, rather than sometimes some of our programmes and projects over the years that we've had to go out a number of times, when you look back and do the lessons learned, we maybe weren't clear about what the diagnostic was in the first place and what the problem was we were trying to solve. We hadn't necessarily thought about what the design was, or engaged the people who were going to use the service to understand what really mattered to them first. We'd made an assumption that we knew, and we hadn't put some of those principles in place, like making sure that we understood what good looked like. Did we have the data to be able to measure it so we'd know if we got there? So in terms of things like benefits realisation, to be able to deliver on that. And also to make sure, and I would say this wouldn't lie, that data and digital are embedded as part of this, because we can no longer in 2024 and beyond deliver any transformation without those critical tools, because it's how we live our lives. And then the final bit that Helen's raised, and I do want to kind of add, is it's a cultural, this is relational as well as being about how we generate ideas. There's lots of evidence in the NHS about how the economy of regard actually delivers efficiency savings. And this improvement journey is a way of being able to harness the capability of our staff, of the, I can never remember the right figure, I hear a different one. It's either 64,000 staff or 35,000 staff, depending on which lens you're looking at. But that's a lot of people that we need to inspire through this improvement journey. So I won't go through the detail of the paper, because you can read those, you can read the pieces about NHS impact and the approach. I don't think any of it will be shocking or, in fact, unfamiliar. I think you'll probably find a lot of it is very familiar, and you'll have seen it over your career. I do think it applies reasonably well to local authorities, but unfortunately Paul Flood wasn't able to be here today. He was going to come along, but one of the things that we need to work through is to make sure that we've got an approach that works for all of our partners. And there are some areas that I need to make apologies at the outset that we haven't engaged. So I've already had a conversation with John to make sure that we engage Tina in Swaston as part of this process, and Chris from a VCSE perspective, we need to make sure that we've got more input and to make sure that we've got a system approach. So it's a mandate from the board to link this up, and actually just being mindful that when the board talked about shaping our future, there were 4 things that came out that we needed to look at, and one of those was a more aligned approach to drive up efficiency around transformation capability. So this is considering that. The other thing, and we talked in the seminar last time, when we were talking about learning disabilities, about the 3 horizons, and this is that horizon 2 space, which is taking us from where we are. We've got a vision, but some of this is about the practicality of not just what, but how we get this moving and how we change the way that 5,000 people tomorrow will change the way that they work, so that we can drive the impact change and experience for the people that we serve. So I will stop there. Helen, was there anything else that you wanted to add or amplify?
Nothing. Thank you. I'll open it up now.
Thank you.
Just I think from what you're saying, although this has a label NHS impact, actually what you're saying is for us locally, this is about everybody, and NHS is important, but we're not going to be defined by that, because actually this isn't an NHS.
No, there is an NHS impact policy guide that we've gone through as a network, and actually sifting through it and changing the P for patients to the P for people actually means that quite a lot of it does align. But there is a different way of doing things in local authorities, so that we've got to make sure we haven't done that work yet to make something that works for all of us, that connects us together. Because often when we're delivering change and improvement initiatives, we all need to come together, because this single organisation focus doesn't work for everything, as we all know.
Thank you.
I think Helen wanted to comment.
And in terms of the assessment itself, it's an interesting title it's been given, the NHS Impact Self-Assessment. Essentially, it's a maturity matrices around developing this type of approach in organisations, and if that helps make it, one size fits all, the NHS language in that is unhelpful, but actually it is just a maturity assessment of developing a holistic approach to doing this in organisations.
Great, thank you, Helen. Open it up to comments, questions from colleagues. Steve.
Thank you, Chair. Thanks very much, Helen. I know if Maria was here, she'd want to say that she is the Southwest rep for NHS Impact and would endorse this approach in terms of going forward. Now, just to echo your points, Chair, that the principles here apply in any setting. To be more data-driven, to harness the capability of frontline staff, and to standardise approaches, I think would be equally applicable in most settings that are around the table today. So I would fully endorse.
Great, thank you very much, Steve. Ruth.
I'm also very supportive of this. I would often talk about interface between organisations being the most important place we need to look, and I would, coming from primary care, and I think having common language and being absolutely clear about what our system priorities are, because there is so much to do, and this shows us a way to be able to do that. So yeah, I would firmly endorse this approach.
Thank you very much, Ruth. Chris, and then Joe, and then Vicky.
Thanks for bringing up that voluntary sector. I wasn't going to raise that, but thank you for acknowledging that. But one of the things I was just going to add, I was on the second tranche of the Peloton training, and I was one of the voluntary sector members. I think there were 4 of us on that, and I think the benefit that we got just even being part of that process was massive, and I think that needs to just keep going through, is actually keeping us engaged, keeping all partners engaged in that process is really important. So thank you for your comments, and thank you for what you've done on this.
Thank you, Chris. Joe.
So just to sort of let colleagues know that this is dovetailing with the work that obviously we're doing now with the BNSSG People and Culture Plan, which is our response to the long-term workforce plan, but set in our wider system context. So it includes our social care partners, our third sector, voluntary sector partners, and primary care in the wider sense. It also is for us thinking about how do we do that upskilling, but it's a cultural change, so it's very much that mortar around the bricks. What are the behaviours? How do we drive that through? And Peloton and other sort of development programmes are part of that, but it is about behaviour changing. So I absolutely agree. It's a method, and it's sort of medium to long term, isn't it? Because that's the sort of change we have to drive. It's a matrix and a maturity model rather than a here's your assessment, here's what you do. So yeah, but it's aligned with the workforce agenda. So,
and one of the things that's quite interesting, if you look at the benchmarks across the country, only 1% of the country, and this is organisations as well as systems, include any kind of improvement training in their induction. So there's a whole lot of other things, but only one. So there's quite good across the NHS. We're quite good at having people who have got leadership positions on boards, who've got improvement, understanding, or professions. But when it comes down to wider staff, it goes it absolutely nosedives in terms of.
So just to add to that, and we believe in the ICB, we should practice what we preach. So as part of the organisational development plan, which is the bounce from shaping our future, improvement training will be part of our induction going forward. So, you know, we'll showcase it as a working example.
Thank you. Vicky, next, please, and then Joe, and then Steve.
Yeah, just to say, really good to hear this fully report, and I'm really excited by the paper. I think in all of the principles it really covers some very important elements of what the system needs to come together to do, and is doing so. And I think the principle of enablers, and in particular co-production, the co-production element of that being an enabler, which, you know, speaks to service users and their unique view on how services work or don't work, and their involvement in that improvement process and decision making is really, really important. And I think it's important for the system to build a kind of mechanism, scientific mechanism that, you know, structurally works and is robust and brings those things together, which have been quite piecemeal, I think, today. So that's great. Thank you. Lovely. Thank you very much, Vicky. Joe, a QI fellow.
So the two things we absolutely do is support this, and in particular that thinking at the beginning, what is the change that we want to have? What sort of change is this? And those of you who do improvement, this is the work of Dave Snowden, who lives over in Wales, talking about simple, complicated, complex, and actually different techniques and approaches are required for different sorts of change. And just spending that time thinking about that and applying the right methodology will actually mean that your changes are more likely to be successful. So the return of investment is worth that little bit of upfront thinking. But that wasn't the point I put my hand up for. What I wondered as a board is one of the things that drives, if you're talking about driving cultural shift, is we need to let our staff who do these improvements be celebrated. We need to celebrate their failures and do their learning. And as leaders, we need to hear it, see it and acknowledge it and celebrate it with them. And I wonder how we do that as an integrated care board. What does that look like? I've seen it, again, I was taken around sort of many institutions around the country, and they will often have improvement events from an organisational footprint. But what would it look like from an ICS footprint? Question mark. And we talk about seminar sessions, but whether one of our seminar sessions per year should be the celebration of PAN system improvement, literally, you know, from our operational workforce up across our sort of multiple provider units. So just to think about what does that look. So we've got to lead by example. We've got to mean what we say. And one of the things I've often challenged is it's easy to stick to the rhetoric here, but you've got to show a tangible commitment to this to make staff believe you mean it. What does that look like for us? Question mark.
As we go through the process of kind of coming back to the board with something that is more structured and we've kind of followed it on, I think if we factor that in and ask people what would make this feel like the board of this ICS and the ICB is actually behind you. So we can ask that question. We can do it the right way. We'll do it with user insights. But I think those are really welcome.
Yeah, thank you very much, Joe. Go to Steve next, and then Sue. I think your hand's up, wasn't it?
Thank you, Chair. I was just going to follow on some of the points Joe's already made, but I'll amplify something. I don't think, if we are serious about wanting to deliver our core objectives in the organisations that we work with, then we have to recognise that investing in this ultimately will improve the quality and the productivity as we build the capabilities, because this has to be embedded. This can't be something that is sort of over there for a few. It's got to be something that we absolutely drive across our organisation. So that's the first thing. I think I'm just amplifying what you said. The other thing is, yes, let's pull out the things that are making the difference, because across the system we've got excellence, fantastic delivery, huge efficiencies that have been created, quality has been improved, but one of the things that we sometimes suffer is that we can't then take that and disseminate and spread across organisations. So they're not invented here bit. This starts to break, if we use this properly, it starts to break some of that down. And I think the final piece is that somehow we need to find the space and headroom in the financial challenges that we're going towards, that we don't lose this, because this will help us in the longer term.
Great, thank you very much. Yeah, completely agree, Steve. Thank you. Sue and then Dave. Thank you.
Thanks, Chair. Really welcome the approach, and when we speak about this stuff often, Debs. I was interested to understand how we think about the whole kind of system transformation map, if you like, and also how within that we consider change load and the amount of improvement and transformation we can cope with across the whole system, but also the interconnectedness and how that links into, a bit to your point as well, Steve, the kind of the medium-term financial strategy, the amount of financial headroom that we need to create in order to invest in some of the things we need to invest in, and then how this helps to deliver better care at lower cost, but putting all those different elements, I guess, of change together.
I love the idea of change load. I think that's really important for that landscape. Do you want to?
I think certainly in my experience, it's very easy at a senior level in an organisation to make a decision. The ramifications of that in terms of what it actually means for people to do in the organisation, I genuinely see at this level we underestimate it every day in organisations. And one of the critical foundations of this type of methodology is genuinely focusing on less to really truly embed and sustain good improvement that you can build on for the future. And it's a very hard thing to do, you know, in a challenged environment. So, but that is the principle of this. We've got to be brave and say we need to focus on a lot less. Because we're going to do it really well, and we genuinely respect the ramifications it has on people in organisations.
Yeah, absolutely. Thank you, Helen. Dave.
Yeah, thank you for the paper, and again, most of the comments I was going to make have already been made, but from a local authority perspective, as you've outlined, we will have our own improvement frameworks in place, and certainly looking at my own, all of the principles that you've laid out are similar to the principles that sit underneath our own improvement framework, and
Carol made sure we did.
Yeah, good, thank you. And many of us, as you've said, have actually invested quite significantly, I think, as local authorities in creating that capability, skill, resource training, and then embedding that across the organisation. And whatever we talk, you know, whether we talk about fast, you know, failing fast, learning from it and moving on, but celebrating what goes wrong as well as what goes well is an important part of that journey. I was going to make a similar point actually about just thinking about if we are going to start linking up improvement journeys across sectors, how we do that in a way where it adds value and doesn't lead to competing pressures, which then dilutes everybody's change programme. So yeah, supportive of that, and supportive to see how we can align some of that stuff together across sectors.
Great, thank you very much, Dave. That's great. Ellen.
Yeah, thanks for this. Just wanted to probably bring it to life a little bit, Deb, if we can. So it feels like we've been on a change journey since we've been an ICB, and probably before that again, I'm sure everybody else is. There's something about keeping it simple, about change fatigue. I just wonder whether we've thought through what this might mean for us as a board. You know, what's it going to mean going forward? What's it mean to the person who's halfway through the Hughes department in the local authority? What it might mean for sort of a patient in NBT. I just wonder whether we've really thought that through. So bringing it to life, and what does it really mean?
Yeah, so I think, so in part, the thinking it through to make sure that we've got that clarity, this is the beginning of that journey to make sure that we do that together, because every organisation is doing that at the moment. Not every organisation and not every transformation leader feels it's an easy journey, so some of it as a board is for us as leaders and as a board to consciously consider what's the improvement. You know, if we're looking at particular programs, what's the improvement methodology here? You know, how are we ensuring and how are we assured that proper improvement science is being applied when we are investing very many millions in a change initiative? Okay. So I think there's something about thinking that through, and then as a board there will be some development that will will benefit us all, to be able to make sure that we know what good looks like.
Okay.
I think the broader piece about how does this all link up, we're at the beginning of that journey, because what we've said at the moment is there's this thing that's come through from the NHS. We've all, collectively as improvement leaders said we've got some real shared challenges and we've got some real opportunity to do more together, as Dave said, to avoid duplication. And that's where the idea of those principles, what are the commonalities and how do we shape this so that that can be something, those principles can be something that this board can own and gain assurance through, so that we start to do that across all of our programmes.
So it's a process that we could apply something small or something large.
Yeah.
Or,
and that's the mandate is for us to go away and invest the time around how do we draw this together, and how do we, like that, the Horizon 2 in those 3 Horizons journeys, how do we think about, we talked this morning about the performance and improvement, the performance and delivery board. How do we create something that is akin to that for our improvement capability and give it the same kind of importance as we go through our development journees? I don't know whether you wanted to say something.
I think really practical. I was trying to think of a really simple way of threading up the real genuine impact where we're needing it and wanting it to happen. This is about ultimately people waiting less time for the services that they need to access, and each time you keep going at this they wait less and less, because we all aspire for a patient or a service user to want to get access to what they need it and when they need it, but it's the little and often keep chipping away at it that starts to make progress towards that. And with lots of great stories of taking little chunks of time out of things, but ultimately that's what this is aspiring to do. I think the other thing I wanted to comment on was language. We've had a number of conversations about language around this table. It's really hard because we get a methodology and we feel really enthusiastic about it and we want to use all the language associated with it, and it can actually put us off in the process. And so actually I think one of the things the maturity matrices does really helpfully is bring it back to what are the 5 critical components of doing this stuff well, and to take out some of that. We're trying really hard at North Bristol to not use the fancy language associated with this stuff, and it's actually quite hard. And I think my ultimate summary of this would be how many of us in the not too distant future will have a Failure of the Year award, because that really would be a demonstration that our culture's changed.
I was just thinking of a diffusion award. Being a failure and an adoption and diffusion award.
Just another thing to say is a bit about access is one thing. The other thing that we've been starting to think about, it's not in the paper per se, but is the conversation about the improvement of health or the reduction of health inequalities, and how that can, be that core that links all of these things together. Because, if we've improved access, we hope, and we've done it in an equitable way, we've also reduced our health inequalities. So actually having that as a core thread of the, what are we doing this for again? Which I think was your question, Alan. Yeah.
Lovely, thank you. And Shane, final comment from you, thank you.
Thank you, Dave, Helen. I suppose a couple of things. Yesterday there was the meeting of NHS chief executives in London. Steve was there as well, and there was quite a lot of the day was discussing NHS impact. A lot of the day, and well, firstly, what we're trying to do is perfectly in line with it. So that's great. So that's a tick, and we can park that. But actually, what was more important was defining what we want from this. Okay, because there's a conversation went on yesterday. It got bigger and bigger and bigger, and before you knew it, it was the solution to everything the world could ever imagine. Okay, and I suppose for me, having started my NHS career as a quality improvement facilitator 27 years ago, change happens at the front line. It really does. Those who know the job, do the job, change the job. That's the way that it works. And I suppose we could end up having this massive, great big thing we call, whatever the heck we call it in BNSSG, but how does it actually make a difference at the front? And I suppose that's the part I'd love you to explore as you go through May and June, is that we could create this beautifully polished thing around this table, but does it make a difference to patients, clients, and others at the front door? So I think it's brilliant, and it's perfect in what we want to do. But it could be the most wonderful academic piece of work we've ever done as this board.
And, and to do that, we failed.
As opposed to something which supports people at the front, whatever front is, whether local authority services, wherever the heck, supports people at the front to make change that improves the lives of people. So I would just ask that we don't do a PA consulting or a KPMG and create a wing of us, which is the improvement wing. We actually think about how we help people do the job better at the front. And that's the bit that I would love us to explore a bit more. But I would stress that we are in the same ballpark from what we saw yesterday. And what would be really important, which was missing a bit yesterday, and I certainly fed back to them before I left, was there wasn't enough about the cultural journey this will take us on, rather than the process journey. There's a lot in the stuff from NHSE at the moment about toolkits and that's fine, but if people don't believe this at the heart as opposed to their toolkit, this won't work. So again, think about what the cultural journey for our system is as well.
Thank you, Shane. So I think there's a sense of real support around the table, isn't there? And I know your ask is for a mandate to work to develop this strategic approach. I think the key questions are how can we be more than the sum of the parts in this? And there will be some difficult decisions along the way, because if we're going to do less things but do them better, that means we're not going to do some things. And so there is something hard-edged about our priorities. And I think, as you've seen, particularly from Ellen's question, there may be an impatience to go from the what into the how. And I think what you're saying is we're at the very beginning of the how journey. And when would you want to bring something back to us? Because I think this is something we'd want to...
In terms of the timescales, I think we're talking about a few months to do the discovery, do the design properly, make sure that we're not creating a beautiful academic exercise, but it's something that's really practical and actually enables us to move beyond the principles about what does it mean we're going to do differently. So I think we were talking in the paper, now I'm just trying to get the paper up again. I think we were talking about 3 or 4 months.
Yeah.
But it doesn't mean, so in the interim we're still meeting, and these, the improvement is continuing, but what did we say?
Well, should we just log it for September in pencil, which is 4 months?
Yeah, it was September in the paper.
It was September in the paper.
That was good guess.
I didn't want to commit. I didn't have it in front of us. I want to commit to something that the team had meticulously worked through, and I suddenly made it.
So let's agree for September. So just checking colleagues around the board table, anybody not endorse and support this approach? No. You've got really good support for this, Deb.
Thank you.
And Helen, thank you very much for coming.
Thank you.
Excellent. Right, let's go on to item 7, which is the important committee updates to the board. The committees do a lot of heavy lifting on behalf of the board, so we'll start off with the Outcomes, Performance and Quality Committee. Ellen, over to you.
Thank you. I'll bring Rosie in at some point to talk about call for concern, and Dave's going to come in on no criteria to reside. Joe, you're welcome to contribute throughout. So, after the last meeting in April, just a few weeks ago, we discussed safeguarding, no criteria to reside, mortality annual report, which was interesting and fascinating, I have to say, and that will be coming back in a couple of months' time. We talked about segmentation performance, productivity and GIRFT, and also the quality report. So it was a good meeting. We've got some really good contribution around the table and some really good members. So we have a very rich conversation. We considered safeguarding, which had been a focus from the Audit and Risk Committee, where it had partial assurance. There's a lot in there for both executive, the committee and the wider system. There's a comprehensive set of actions which Rosie is following up on, and also there are a number of system actions which you're going to follow up with the auditors on. So that was a really good discussion. And the committee will bring forward an effectiveness review. We do this annually, but I'm keen to do that a little bit earlier, because I think some of the actions from the audit highlighted areas where, particularly on statutory items, we need to bring them sort of into the body of the meeting sort of more regularly. So that was an action for us. We talked about no criteria to reside in some detail. Shane talked at the beginning of the year that it is probably one of the biggest challenges for our system and impacts everything, really. An awful lot of work is going on with Dave and Sue. I'll bring you in a minute. And I think what we sort of identified is there are 3 key areas: admission avoidance, reducing complexity, and discharges. And there's a mix of capacity and process issues, which are equal in measure. I was quite keen to understand that. So, Dave, I don't know whether you want to just quickly update
I'll just add a little bit more, and yes, myself and Sue are heavily involved, but so many others around the table, and I've been working very closely with Steve and colleagues in developing our improvement plans for A&E standards, but linked to that no criteria to reside and occupancy. And the approach that we're taking, and I won't go through the whole presentation now, but the approach we're taking is to set ourselves very clear ambition for reduction in no criteria to reside and therefore bed occupancy. At this point in time, we're setting a trajectory towards delivery of the kind of regional average of around 15% no criteria to reside, with a trajectory towards that between now and the end of H2. And we're setting clear trajectories and KPIs towards that. We're then taking a very kind of pragmatic approach and practical approach around assessing the impact of our current plans and our current actions against that and where that gets us to, and then taking an assessment of where we need to go next and further to achieve those trajectories. But as Ellen has just said, the approach we're taking that is a whole system approach. We can't just look at the discharge process at the discharge end of this. We have to look at our whole emission avoidance, supporting people better in our communities and at home. We need to look at our discharge process as well, but also we need to make sure we're looking at our discharge process not only in the acute trust. Sorry to keep pointing across the table, but Steve's over there, I can't see Stu. But we need to make sure we're looking at the totality of discharge process across our AWP bed base and in the community bed base. So we're taking a whole system approach to that. And finally, then I'll bring Sue in. We are taking whatever support we can to support us in delivery of that. We've recently had some better care funded support through an organisation called the Whole System Partnership, who have been helping us in our capacity and demand modelling work, and also around our culture and leadership in relation to this programme, and really making us think about a home first concept as opposed to just solely a discharge to assess process. And Sue, we had a really helpful workshop last week. I don't know if you want to add to that.
Definitely, thank you. So as a culmination event, I guess, to the work that WSP have been leading on around D2A, we held an event with key system partners at senior level across various different organisations to come together to think about what next, looking particularly at the kind of relational elements between us all and how we work effectively together as a system, but how we now move forwards, recognising that D2A is one part of a process of improving the no criteria to reside position, but the real value and potential, I think, exists in the prevention of admission space, as Dave's just spoken to there. And we're very keen now, I think, to move forward to look at how do we bring all these different elements together. How do we as a community provider work effectively with acute colleagues to look at how we can help shift resources to community to do more of some of the really important work that's happening around face, around kind of react at the front door, in order to be able to prevent people from going in. But when they do go in, as Dave's absolutely said, making sure that we can discharge people out as quickly as possible onto the right pathways, but also recognising not all of those people will come out into a community pathway within Serona. So I think they're really key things that we need to take forward. There is a proposal with me at the moment within the organisation to further the work that WSP have been doing through the Better Care Fund work, to look at how we extend some of the capacity and demand work, to look at how we also understand the capacity that exists to help move people out of community beds home, whether that's around Care Act assessments or, you know, the provision of the right amount of support from care going into people to moving out of those beds. And as an organisation, we are also very actively looking at our own length of stay in some of our community beds. And there have been some really successful MAID events in terms of trying to get people out as quickly as possible so that they are not staying longer than necessary, because as we all know, that can also have a detrimental impact on people for being in a hospital bed too long.
Okay. So that's no criteria to reside. It's going to be a focus continually at the committee, because it's just such a key piece of work for so many areas. Hence, you know, in June, I think, again, I mentioned earlier on about the new committee setting up, Shane. I feel there should be a focus for that, and then, you know, we as a committee then can receive assurance on the performance. So that's quite a challenge in performance, 15% against where we currently are now. So quite a bit to do, I would say. In terms of general performance, following the national focus on 4-hour standard in March, BNSSG delivered 73% against a national figure of 74%, which was a significant improvement and a notable achievement for providers. And we're looking to achieve 78% by March 2025. Category 2 times remain good, and elective has shown a real improvement, particularly on 104 and 78-week waits, and we have a few challenges on 68-week waits on specialist areas. So that's an area of focus for Dave, and cancer continues to be performing at a high level. I've mentioned segmentation briefly. We are in segmentation 3, which is the NHS System Oversight Framework, the current one, Mark, and I'm assuming you mentioned there's a new one coming, so we'll flip onto that when it comes through. There are 4 segments, and we are looking to get into segment 2. The challenges we have are cancer, FDS, elective, mental health, and learning disabilities and autism. So on 2 or 3 of those, we've made some significant improvements, and there's a couple that we continue to focus and work with providers with. We had a good session on productivity and GIRFT, and we are inviting the Chief Operating Officers to the next meeting, so looking forward to that in June. So that's generally...
Thank you, Ellen.
Sorry.
I was going to say, Ellen, have a think. Is there anything you want to escalate to the board, or is it just all for information? So have a think when you bring, if Rosie wants to come back in.
So just the item I wanted to pull through from the quality report and from the System Quality Group was a really kind of deep discussion around Martha's Rule, and board members may well be aware from media that Martha Mills is a young girl that died from sepsis, having had a pancreatic injury while riding her bike on family holiday. And her family had raised concerns about her care and treatment. This is not in our system, this is elsewhere in the country. And her parents had raised concerns about her treatment, which were not responded to, and then Martha died. And Martha's parents, particularly her mum, have campaigned tirelessly to make sure we understand the consequences of that and what we need to do in health systems. And Martha's Rule requires NHS providers, particularly trusts specifically, to be able to provide a second opinion when families raise concern, to make sure that we take consideration of those concerns by a family member or a patient, and that where needed a critical care outreach team comes to see that patient and provides the treating clinical team with specialist support. So we had a conversation about that and about a recent death at MBT, which they've been reflecting on. Both trusts are working very hard on implementing call for concern. We've got actions already underway. It was a really helpful session to kind of compare and contrast what the 2 trusts are doing, and they're going to do some joint work, particularly around evaluating how successful their procedures are around that. And we also then discussed what that would mean for other organisations in the system. So a really another good piece of system working about making sure we evaluate properly, and we're looking for some support perhaps from one of the universities around doing that, and how we then make sure we not only apply it inside our acute provider organisations, but what does it mean wider? What does it mean in terms of hearing and understanding when people using our services let us know that they're concerned? And we then follow that up with a experience session, the following System Quality Group, and we're setting up an experience of care group in the system to sit under the System Quality Group. So 2 really productive conversations, but obviously based in very poor experience that some families have experienced. I don't know whether Steve, you or Stuart want to come in on that. I know you weren't there, but your teams are there and engaged really powerfully in that conversation.
Yeah, we welcome the introduction of Martha's Rule as the first thing to say. Our clinical teams are really aligned with this. We're actually quite progressed in our delivery of this in the Children's Hospital. in terms of the outreach team and the functionality we have for informing families of their options. And comparing ourselves across the Children's Hospital network, we are more advanced than most, so I think actually I can be quite assuring about the delivery of Martha's Rule in the Children's Hospital. In adults, it's less clear-cut in quite how it's going to work. We have the components in place, and again are very willing to move that forward if there's any areas where we need to. I think we have submitted a bid to the national through the national process to identify the pilot sites for delivery of Martha's Rule. The outcome of that is not yet formally known, but we're optimistic in terms of how that bid will land. So overall, I think it's a really positive development.
And what was clear as well from the Children's Hospital particularly was the level of co-production with families. So that was really great. So all the materials that have been produced have been reviewed and redone with families using the services and children's. That was really good to see as well.
The local learning MBT you mentioned has driven this at pace in that, and I think that is right and proper that they did that. This, along with some work we're doing on the deteriorating patient, it goes hand in hand for us as a trust, and I think they're very, very well progressed now. I think things are looking good for that national recognition, the pilot thing. I think that's probably going to go favourably for us.
Thank you. Fantastic. And Ellen, do you want to say anything?
Sorry, just one more minute.
Yeah.
Could Joe just update on the annual mortality report and then a couple of words from me?
So I just think that the mortality group started in July, so it was an opportunity to consider an annual report for the Quality Committee. And I think it's just worth telling about the headline news that our excess mortality is still above what it should be, and it is going in the wrong direction. It's slowly got worse this year. It hasn't improved. We've done a lot of analysis using consultants in public health from local authorities, and our shared consultant in public health, Viv Harrison, has analysed all of that. And most of it's driven by cardiovascular disease, which is why cardiovascular disease ended up being our strategic priority. The use of hypertension screening, the primary and secondary prevention of cardiovascular disease has to be a priority, but there is loads of work going on across all system partners, from primary voluntary sector, community pharmacists on that. The bit that it has exposed, which I think did surprise us, is the impact of liver disease. And the fact that in our most deprived populations, the average age of death from liver disease is 51, and that is 16 years younger than if you're the most affluent populations. So it's a really marked health inequalities gap, and that is considerably worse than the national averages and the regional averages. There's something going on in the BNSSG population. So we've done all the work on the sort of the public health data, and what we're doing now is working with the dynamic population model, which Deb showed you at the last meeting, to say, well, what do we know from all of that data that's coming in from that Cambridge multimorbidity to identify the pockets, the general practices, the walls where this is an issue, and then deep dive into that so we can design interventions that starts to narrow that gap. And I think it's a really good example of how health inequalities, the use of the data tools that Deb has been describing, it's a real tangible example of how you use these tools to keep drilling and drilling until you get to, right, we're going to try this intervention to see if we can drive some impact. It's a very specific, but the liver disease one, which is, it's our 5th most common cause of death, but there is something very unusual happening in our population compared to the region. So that's what we're exploring now. And we're developing mortality dashboards so that we can have much, because all of this is done by bespoke reports, done across our public health and BI teams. So we're trying to see if we can develop a tool where it's much easier to access, and we can just, you can self-serve and pull that report off. But that's the work that's being done currently. I just wanted to tell the board that so you're aware of that issue.
And I will open all of this section up for comments and questions when you're happy to finish, Ellen.
Okay. So basically, there's nothing to escalate, but my priorities for the committee, for the next committee, are learning disability and autism, which is on the segmentation, it's the area we've not moved on, autism and ADHD, diagnosis in children, significant backlog, and transformation piece. So again, that will be for the next committee, and continuing on no criteria to reside. And the other the other important piece of the last meeting was the EPRR, so I don't know whether we need to cover that day.
The EPRR policy, thank you, Ellen, was approved by the committee. It's the annual review of the policy. It's here for information, but it was approved by committee. So it's just for information.
Great, thank you, Ellen, and everyone for your... Are there any questions or comments for Ellen or any other colleague? Steve?
Can I just go to the point of the no criteria to reside, and can I just thank Dave in particular for the work that he's been leading in the system on this. It's been a really, really structured piece of work, which has been very engaging. Doing the very thing that we were talking about a moment ago in improvement terms of following the data, taking a structured approach, looking at the evidence. And I take the point that 15% is an ambitious target, but it's a point at which we're starting from an outlier position. So it is a really, really right and proper thing that we really move towards this. Because when we do this piece of work, I think we will, for the first time, see one version of the truth in terms of understanding the similar currency and where the issues lie. And it will allow us to step back as a system and understand how we use our resources in the whole to address this problem, rather than sort of pointing around to see where it can be improved in one part or another. So a great piece of work, and I welcome it.
Thank you, Steve. It's really good to hear feedback like that because it's so busy and people are working at such a pace it can be forgotten. So thank you very much for that feedback there. Chris?
Thanks, Liz. So it was just a really quick one on the EPPR, and I might actually catch up with Dave after this session if that's okay. But there's a few things I wanted to feedback on that. Is that okay? So I'll catch you later, Dave. Thank you.
Thank you, Chris. Dave, over to you.
Yeah, thank you, and thanks for the great report, and just a quick one as well for me in respect of the children in care section in the report. I think I mentioned it this morning. We've got some concerns around about dentistry access in relation to children in care and care leavers, so we'll certainly be doing a focused piece of work on that, and it'd be great to engage with the ICB in that piece of work as that goes forward.
Definitely, thank you. Can't see any other comments. Ellen, thank you very much. That's brilliant. Jaya, over to you. I'm sorry, we are noting the EPRR policy, but it's been agreed by committee. Jaya, over to you.
Thanks, Alison. So we've had a few challenges on attendance and membership, which are now resolving or resolved with the terms of reference. Very big thank you to all our colleagues who have continued to support and attend the People Committee. We've obviously got a huge challenge, a robust programme of work underway to address them, all aspects of workforce and workforce development, so that input is critical to our success to be able to support system objectives. As part of joining things up bi-directionally, for the first time updates were taken from system partner people committees so that we can join things up both ways. This was really reaffirming in terms of our synergies and priorities, including completing priority plans for 24-25, analysis and action following the people survey results, and our focus on values and behaviours, especially linked to the quality of appraisal conversations in the engagement and retention of staff. So these partner people committee reports are now a standing item so that we look forward to sort of supporting what's happening but also feeding things back up and down. We're continuing to monitor key workforce metrics on a monthly basis to ensure we're on track. Month 11 presented a positive picture in terms of turnover, sickness and recruitment. Bless you. It's not to be sneezed at. Good headway is being made on the agency spend and the transfer of staff to bank roles. And this work is continuing at pace with regional colleagues to remove off-framework arrangements across our system. We're very keen to expand further the social care workforce data and have taken an action to work through how we can also make general practice and primary care parts of our reporting. We've agreed that productivity should be a focus during 24-25, which should be no surprise, and that the People Programme Board should lead a specific work stream identifying system-wide collective opportunities from the current work being done locally by partner organisations and taking full advantage of support on offer at regional and national levels. An ICB lead has been identified and a task and finish group will begin work in May. We've also received an update on the regional and system work focused on temporary staffing and agency activity and the target requirements from NHSE, which all partners are engaged in meeting. Price cap compliance will come into effect from the 1st of July, and we're on track to meet this date with a nursing rate card already live and a medical rate card to follow in December. So nursing was the main priority to date, but attention will now be taken towards medical. So that's it for us.
And does anything to escalate to the board?
Currently, no. It's just pushing ahead on something so that we can continue to report.
great, thank you. And we're deferring the Sexual Safety and Healthcare Charter till July, which was on the agenda, aren't we?
I think actually that can come to the People Committee and it can just be it will just come here as an update.
Great,
yeah.
Perfect. Okay. Is there any? Joe, did you want to add?
I was going to mention the Sexual Safety Charter,
sorry.
so no, that's absolutely fine. Thank you very much. No, that's great.
Okay, lovely. Any comments or questions for Jaya on People Committee? It's a really clear update. Jaya, thank you very much indeed. Steve, over to you for the Finance, Estates and Digital Committee.
Thank you, Chair. And in your pack, you've got 4 papers, 2 sets of minutes, the finance report and procurement policy. Happy to take questions on those, but I do want to just highlight some headlines. And the first is, colleagues, this time last year, we were sort of signalling quite loud and clear that whilst we had managed to create a balanced budget, it did require us to take action in terms of working together as a system to deliver that balanced budget. I'm delighted to say you fantastically pulled that off in terms of delivering that, and that meant that we were able to write off the historic debt, and that's good news, so that's fantastic. And we did deliver the break even, which meant we were not going to be under the helpful and watchful eye of the region. That's always a positive. But we managed to do it in part by managing our finances in such a way we did one-offs to cover some of those challenges. We now have to move to a slightly different position where we build in a sustainable way of making savings. So I'll come on to that in a second. But good news in that we managed to end the year well. And I think that should be noted by the committee, by the board, and congratulations to everybody in the system for making that happen, and the fantastic work, hard work that went into delivering that. As we look back, at the same time as closing everything down and creating our annual report, which is work in progress, we're also having to look forward, and of course that required the teams to work very quickly through the advice channels to make sure that we could present a plan which was submitted and will be discussed in May with the region. Again, we've managed to create, with some risks not mitigated, but we've managed to create a plan which will be discussed but will require us to make continued savings. This year, as Shane signalled, is a very financially challenged year and will require us as a system again to make significant savings, which we have built into our plans, so we're assuming that we're going to deliver those. We will obviously track and monitor that very, very closely, and you will have heard actions that we'll be taking to assure ourselves that on an ongoing monthly basis we're on track. Really, really important that that's in play. I think the other thing that I'd just pull out is that in many of the conversations that we've been having, we keep turning back to the need for us to have really good identification of data and digital systems and connectivity that allows us to make sure that we can draw on all of the data sets in a joined up way. That also requires us to recognise the increasing need for capability in data science, data analytics. But before all of that can happen, we actually need some support from our clinical colleagues to make sure that we are looking in the right places and asking the right questions. And a fantastic example that's just been given in terms of trying to understand why we're seeing certain things that seem not to be the case nationally. The liver disease is a really good example of now we need to look and track the data, drill down, and we'll need to make sure that our digital infrastructure is sound and our data analytics is sound in order to do that. So I'm delighted to be able to say that we've managed to appoint Professor Phil Clapworthy as a Chief Clinical Informatics Officer, who's going to be chairing the Clinical Informatics Cabinet, and that's really important because we then have clinical input from the very start to help us shape some of this. So I think that's a really important thing, and remembering that the Finance, Estates and Digital Committee, sometimes just it might appear that we focus on finance. We don't. We do look at other things. And we're also very cognizant of the fact that whilst getting the finances to land well is really, really important, there are clearly close links with how we consider workforce, our people, and how we also think about the quality and make sure that the three-legged stool doesn't become a one-legged stool and falls over. So finance, quality, and the delivery of the care that we need to deliver for our citizens is critical. So I guess our committee is trying to balance some of that across. So thank you to colleagues for nudging me when I need to be nudged to remind me that actually look across, but also for the teams for doing that behind the scenes as executive members. It will be a challenging year. I think we've got a robust plan which will come back here once we've finished the negotiations with the region, and I think I can probably stop at that point. One area that you will see in the papers which we'd flagged as an area of concern for us was around funded care, and we've just recently done this month, late April, we've done a deep dive into that. And I think we've managed to work out, to a degree, where and how we can start to manage that in a slightly different way to control some of the costs, because it's going up at an alarming rate. So the funded care piece, and obviously we need to work backwards now with you to make sure that we haven't missed anything. Sarah, have I missed any key things?
No, probably just two other things I'll just quickly draw out. One, the procurement policy is here. The committee signed that off. It's in line, it's having its annual review, but there has been quite a bit of legislative change, so it's reflecting that. And then the only other thing to add is that we have now had the requirements for the infrastructure strategy, which we had an update on at last month's committee, and we will obviously be bringing that back through the board over the next few months. So those are the two things.
Sarah, can I just check on clarity? It says on the agenda we're approving the procurement policy, but I think you're saying...
It's basically to note, because under the scheme of delegation, it's with the Finance Committee.
That's great, thank you. I was going to say, did Debs want to say anything? But, in fairness,
I think she's in shock share that we've managed to...
but I won't.
The chair managed to cover it.
Any comments or questions for Steve around Fed, Finance, Estates and Digital Committee? Or anything to Sarah? Jaya?
Actually, it's in relation to the procurement policy, which is listed in there. And I'm not expecting you to have an answer immediately because it's quite a big question, but it's to do with PPN 0223, which is about tackling modern slavery in supply chains and how we address the fact that modern slavery is on the up, especially in care sector and other sort of very at-risk sectors when we've got shortages in workforce. What measures are we taking to make sure that our suppliers are encouraged very strongly to make sure they're doing their due diligence?
I'm not going to try and answer that now.
That's right. That was a big.
That was
for a later.
I know that the team had thought.
Thank you, Jaya. Chris.
It was also on the procurement policy as well, and was just to flag up that on the social value, there's a bit of work going on at the moment to make social value more of a thing than just a box-ticking exercise complying with central government legislation. And again, this is the opportunity that the ICB has to invest in its local objective 4 of the NHS Charter, which is about working with local communities to strengthen economic and social development. And actually, I think, the next iteration of this policy needs to have a stronger sense of social value in that, and use that as an opportunity to be active in that space rather than just ticking a box to say, oh yeah, we've considered that. So I think we just wanted to flag that up.
No, and that's great, and we'll be pleased to hear that Mark Hubbard is spending quite a lot of time with Helena Fuller, really trying to make sure that we are driving that.
We're looking on the community mental health partnership stuff that's out at the moment. That's the thing that's driving the discussions on that, so just so colleagues are aware of that.
Thank you. Thank you very much, Chris. I can't see any other... Stuart?
I was just debating to myself and I almost didn't. I thought, actually, I've got to. And I know everyone in this room will know this, But talking about the System Estate Steering Group and the infrastructure strategy, I just have to reflect back the significant risk associated with the current CDEL limit for this year in terms of both operational delivery, but also in terms of that digital piece that you just mentioned, Steve, in that the next step for the maturity of our digital infrastructure is that we've got to get those foundations and basics right. That needs CDEL investment, and we want to drive a data-rich environment and make really decisions based in really competent information. Well, there's a real challenge to that sits right here in that CDEL limit, and I think we just got to ignore. I know it's really constrained. I know where we are. But I think we should at least acknowledge the fact that we are confronted by this really difficult dilemma of how do we drive a data-driven environment, how do we drive the operational performance we've spoken about earlier when we're in such a constrained CDEL environment.
And
Please do, yeah.
Because I think, one of the things we've been doing is really working on that infrastructure strategy, and infrastructure isn't just about estates, it is about digital, it is about workforce as well. And really making sure that we're using it as a bit of as a tool, both to inform the next comprehensive spending review, to sort of be clear about what those priorities are for our system, and also to think about then what the priorities are within our system once we get any allocation. But it is, I think at this point, we've got to be very clear about what are our priorities and how will that drive forward the services that we're able to deliver. So really keen to make sure that we are representing that.
But you're absolutely right. I mean, the challenge for us this year is that it's very, very tight. Clearly, we've got to look, there's got to be a bit of hope in this, which is 2025, 26 should get easier, I hope.
27,
29. That's what I have to say about the university one as well. But so we have to prioritise now. What can we do now? Because some of the stuff we want to do really is about invest to save and invest big to save, and that's where I think we're a bit constrained. But you're right. You're absolutely right. And the estate is a similar story. The digital, but also the physical estate. It's the two together.
It's the two together which give us the double whammy.
Exactly.
Thanks very much for raising that, Stuart. Shane?
It's actually a question of Sarah as much as anything. The 3.4 billion that has been identified, albeit on the back of efficiency savings, is the CDEL limit being lifted to enable us to spend that 3.4?
So it's not in this current...
No, it's next.
So obviously, well, it's not... So that is part of the next comprehensive spending review, which I think the infrastructure strategy that we get in this summer will feed into that. Yeah.
Yeah. That's my hope bit.
Always good to have hope. Thank you, Steve. No other comments or questions on finance, estates and digital, and we're noting that the procurement policy was approved at committee. Next one is Primary Care Committee, which I had a couple of things to say. In general, I think there's a really good emerging, mature relationship of people around the table. I'm talking particularly about the local committees, local medical committee, dental committee, pharmacy committee and optometry committee. They are always around the table and they are always engaged. And I think what's really clear at committee is that there are enormous challenges within different parts of primary care, but there are also quite a lot of opportunities, and I think that's what we're trying to do in committees, to understand what the opportunities are of having delegated commissioning now. So, and I think those maturing relationships can only help us to get to that point. So I think Dave and your team working behind the scenes, which you've done for well over a year now, is really helping. We've already previously looked at the first draft of the dental strategy, which came to board, and there is now work ongoing with the pharmacy strategy at an earlier point, and also an optometry strategy. So it is important when you inherit 3 different services that they get time to be in the spotlight and focus on their service. The 3 things I was going to mention specifically, one is around the BMA, which Shane has done, and the emerging risk there, so I won't repeat that. nothing to escalate to board, but two things for board's observation. One is we saw for the first time a really brilliant dashboard of really good, comprehensive primary care data. It was ever so good. And what we also heard at committee was that practices are seeing their data, and those practices who share data are seeing other practices' data. But what emerged at committee is that not all practices are data sharing. There's still a proportion who aren't sharing data. So what that means is, A, we don't see their data, but more importantly, they don't see their data compared to their colleagues. And I've had a quick conversation with Ruth, because the question is it a technological barrier to data sharing, or is it a philosophical argument against? And I think, glad you're back in the room, Debs, because, and Ruth, you may want to come in, but the benefits that we saw, and we wouldn't be using it on a day-to-day basis, would be, I would just encourage practices to share data, and if there's any support needed, that how we can help that, because what we're starting to see is those comparisons which are really healthy. So that was a good thing, and I'll bring you in a moment, Ruth, if that's okay. And then the area of a risk really is the dental commissioning hub capacity. With the new arrangements, the dental commissioning hub is across the southwest, and the ability of the people in the hub to be able to serve us with the extent of the transformation we want to do with dentistry is limited. It's really limited. So there is a question for us as a board about what can the hub do for us, and I know there's lots of discussions at lots of levels. And if it can't do what we want to do, what do we want to do in terms of that? Because I think at committee, and Dave will say this, I and others do say, well, when are we going to do that? When can we do that? Can we see the priorities in 6 months? Can we see that? And actually, there's a whole piece of resource needed to help with that. So it's a risk, and I think you're working through. You may want to come in on that bit, Dave. So those are the two things. So Ruth, did you want to pick up anything on the dashboard about data sharing?
Yes, so there has been a historical issue. From what I understand from conversations, it has been put forward that there are technological limitations, because particularly some of the very large PCNs, once you start to run reports on their data, it can take up to 3 days to run that report, and it really slows down the operational EMIS functionality, the day-to-day EPL functionality. So there are some things that we have suggested to do to mitigate that, so I think we need to test those out. We've been talking to Deb's team about that. So we're taking those approaches to try and resolve the technological approaches, and then we will find out if there are subsequent efforts that need to be made.
Yeah.
Just to add to it, I think what's really helpful is the Andy and the ICB has been working really, really closely with Ruth's team. So I think it's about having that join up, making sure that we're doing things seamlessly, that hopefully we will get to a point that we'll really understand. Because I think there's lots of views and lenses on what the problems are. So what we're doing at the moment is the things that people are presenting are problems, the team are looking to present other solutions, we test them, we find out, we kind of peel away layers until we actually get to whatever the real root cause is. So it might not be a simple fix, but we do need to work through that. In addition, if there is anything that is in the IG space, and we are bringing that to board next month or the month after, we have been working through an IG charter, data sharing charter, which Joe as Caldecott Guardian and all the system Caldecott Guardians, myself as CSIRO and the system CSIROs, we've been working through a charter around that. So if we can solve the technological problems and we make sure we're dealing with the IG problems, hopefully we've got most bases covered and we'll get the solution as soon as possible.
Well, that would be great. We'll clearly watch this space at committee.
Last time I was reading the NHS operating guidance, and there is a line saying there is an expectation for all of primary care to share at bare minimum ethnicity data, and the ICBs are expected to ensure that. So there is also just a little backstop there in this year's current operating guidance, just to note.
Thank you. Dave, is there anything I've missed from primary care, and also about the commissioning hub risk?
Probably not a lot more, Alison. The commissioning hub Yeah, I think you probably said what I needed to say. It's currently hosted by Somerset ICB, when we're working with them on making sure we're supporting the hub and focusing the hub on the kind of priority areas across the southwest region, and those conversations are ongoing. So work in progress.
All right. Thank you, Dave. Any questions, comments on Primary Care Committee? No. Okay, John, Audit and Risk Committee.
Great, thank you, Chair. We just had the February meeting, our February minutes this time, and there was a lot of material around digital delivery and Project Gateway, capacity to deliver system transformation and so on, so very relevant to the impact on item and conversation that we just had around improvement and change. Although we don't have the April minutes, I just wanted to pull out a couple of points from the April meeting, because I think it's important in light of where we are in the year. Because the Audit Committee has delegated authority to approve the final report, the annual report and accounts. So just to flag, at the April meeting, we received a near final annual internal audit opinion from our internal auditors, and at this stage it provides an adequate and effective opinion with some further enhancements identified, and that's a good place to be. The year-end audit is ongoing, and Steve has mentioned the break-even position, so that's just being worked through at the moment. The committee is currently on track to deliver the work plan for the year, and we have an agreed work plan for 24-25. The two partial assurance reports have already been flagged around funded care and around safeguarding. I think it's fair to say their areas of fairly long-standing challenge, and it was really helpful to shine a light, to use audit in a way that shines a light and draws on the experience that our internal auditors have. They audit 50% of the ICBs across the country, so they have access to really good practice, and I think we got quite a lot of benefit from that around how we can improve as a result. So it was just I think we had helpful feedback on that, and I just wanted to recognise and reflect that in light of the fact that it's come up through other updates. And I don't think I have anything that needs to be escalated to board answers, so thank you.
Well, thank you very much. That's great. Any comments, questions to John on Audit and Risk Committee? It's good seeing how it's interconnected, isn't it? The audits you talk about, Ellen's talked about from the committee, so joining the dots is important, isn't it? John, thank you very much indeed. Shane, did you go to the Integrated Care Partnership?
I did.
Is there anything you wanted to pick up from that?
Just to update, we had 4 main areas of conversation. The first one was South Bristol locality, presented on a lot of the work that's happening locally. So that was South Bristol, which was great, and that was very much just a sharing opportunity. There were 3 then substantive discussion points. The first one was on locality partnership review, and obviously shared as part of my Chief Executive report. The next one was the outcomes of the board-to-board development session. So those of you who attended the board-to-board development session in Bristol City Council, there's now been a set of slides created which reflects on the output for that. We'll bring that here to the ICB as well, but it was shared with the ICP at the last meeting, and really tries to look at the strategic arm of the ICP and the delivery arm of the ICB, but we'll bring it back, Chair, to the next meeting. And then there was a considerable discussion on the service strategy work, which we brought here through Sarah before, and really helping the ICP to understand where we're going. And actually, it generated a huge amount of conversation around how the wider context of our partners could really become involved in that service strategy. And that actually generated a lot of excitement, and people really want to be part of that conversation. How do we take our strategy and turn it into what are the services need to be for the next 5, 10, 15, 20 years? And services in the widest context, not NHS services, but the things we all do with and for our public. And that was really a really good conversation. So that was the 3 main areas. And just to note, it was Councillor Helen Holland's last meeting as chairing the ICP, and clearly the baton turns to South Gloss at the next meeting.
Great, thank you very much, Shane. Any questions or observations for Shane around the Integrated Care Partnership? Chris?
It was a good representation of the meeting, Shane, and one thing that we took away from it was that partnership whilst it's everybody's responsibility to be in that partnership, it does take some work and some oiling to get the thing going. And I think we just flagged up that there was that we mustn't lose sight of that, that in all of the sort of the, you know, everybody's behind it, but actually we need to have the infrastructure to make partnerships happen. And I think it felt it was a very positive meeting. So I don't, I'm not taking away from that, but it's just recognising that we do need to have something in place to make those partnerships actually work properly.
Does that make it, do you think there is something lacking that should be in place, Chris?
Well, I mean, other than it was Ros Cox's last meeting, and Ros is her title is partnership manager.
Right.
And so actually it was just recognising that within that context that it needs to be recognised that partnerships need to be maintained.
Yeah, I think we should.
That is part of the responsibility in my role now, and obviously sad to say goodbye to Ros. She's, you know, staying within our system, so that's really positive. But we will, yeah, it's a useful reminder, Chris, and we'll make sure that that's kept front of mind. Yeah.
Thank you, Chris. Okay, I don't see any other questions. We're on to item 9, questions from members of the public. Brian, thank you very much for staying with us this afternoon. You've submitted 3 questions beforehand, which you're happy for me to read out.
Can you do 1 and 2, and then, because those are connected together, whereas the other one...
Yeah.
So I can respond to 1 and 2 first of all.
Yes, I shall do exactly that. And there are no other questions I received from members of the public. So questions 1 and 2 from Brian. Is it intended that there will be a public annual general meeting of the ICB in 2024? I know that there was not one in 2023. I'm not sure if the ICS, since it was formed, has held an open meeting with questions from the floor. Irrespective of whether a public meeting is held, would it be possible for the ICB to produce a summary report for general circulation, not exceeding 2 to 3 pages, extracting information from the formal annual report covering subjects such as total income from NHS England, how much money has been spent on its various activities, and the performance against the government targets. In addition, a formal statement on its achievements against its target to be carbon emission free by 2030. And those were the 2 questions. And obviously, as usual, Brian, you will get a written response as well. But Shane, I know you wanted to...
Yeah, absolutely.
Can I just say something?
Oh.
Just to add to why I've done it. Originally, I suppose, when the National Health was set up, there was an idea that there should be a considerable amount of public involvement. Since my attendance here over the last 10 years on and off, just as a member of the public looking at it, I think the sort of connection with the public now is more and more remote in this year. It's quite strange there's no elected members to these sorts of things. You know, I think that all I see where there's any significant contact is in the actual AGM when we have a person-to-person one. And that's why I would like to see it again. And also, it would be useful, I think it is a little bit short version of the report, the annual report, distributed or available to the public. Sarah, does a wonderful job, I think, in balancing the books. And this year it's rather good news for the public. It would appear we balanced them well enough to get rid of the overhanging debt. And that would be useful for the rest of the public to realise. And, you know, my various conversations here very often involve Sarah because of my green issues. But so I'd like your response on whether there will be an actual personal AGM.
So, absolutely, Brian, there will be an AGM this year. Yet to be defined in terms of exactly where. We were discussing it earlier. So yes, there'll be an AGM. Last year we presented a series of summaries online, whereas we're actually going to do the online and a physical summary as well, so people could have something physical. So there will be an AGM, there will be a summary. I think what's interesting is a lot of our engagement with the public certainly has gone down other routes, such as like the Health and Oversight Scrutiny Committee. So we would be scrutinised in public by the local authorities and that kind of thing. Because you are correct, we don't get an army of people who come along to our board meetings. But there are other vehicles in which we are scrutinised. But we want to make a big thing of the AGM this year and use it as a celebration of the work that has gone on in the year and be able to share that back with the public.
Great, thank you very much. Question 3 from Brian is around the procurement policy. And in paragraph 8.7, Sarah, greener NHS delivering a net zero national health service, there's a requirement the ICB will drive the supply chain to net zero, using the present ICB green plan as the basis to achieve this. Brian is very interested in knowing how this will be done, as the plan as it's issued at present has not even yet made a formal statement on its present emissions. Yep.
Reading that, I just happened to come across it, and when you think about procurement, basically, normally is how much is it? You see, that's the dominant factor. But now, with the green issues, it's not only how much is it, but how much are you going to reduce emissions? So, and to make that decision, it's going to be much more complicated than the past. So, I think that this task, and we can see now that people are backing away from 2050 cycle. We're committed to 2030, which is only 6.5 years away. So I don't really think we're going to make it, honestly. But we're going to have to make a good try, and all I'm trying to do is emphasise the fact that it's quite critical to try and get these things in place if we are actually going to. I mean, we can see the effect of it already with this spring, the so-say spring we've had, continuous rain. Which shouldn't be surprising to us, and it's starting to get worse. So it's just my plea to make a big effort to put it right.
Thank you, Brian. I will let Sarah have the ability to respond.
Thank you. And Brian, you know that this is very much work in progress, but we have within our Green Plan Action Plan, which is overseen by our Green Plan Steering Group, there are things like, for example, training all of our procurement specialists to make sure that they are as competent, in terms of when we're looking at procurements, that we're able to evaluate on carbon issues as well. And, we've got commitments in there, for example, like having 100% of our new medicines contracts have carbon reduction plans within them. So really, it is a work in progress, but we are making progress towards it, but I'm happy to do a fuller response that sort of sets that out for you, Brian.
Thank you.
And if I may, then that links back to your second question, Brian. We'll make sure that's part of the AGM as well. So it's clear at the end of the year when we celebrate what we've achieved, we'll also be very clear about where we are in our green plan.
Thank you for raising those questions, Brian, and you will get fuller responses in writing. As I say, I don't have any other questions. Is there any other business around the table? Starting, Chris, with you at the top there, just working my way around. Coming around this way? Nope. Going round the bend? Nope. Okay, great. So I'm happy to close the meeting. The next meeting in public is Thursday, the 4th of July. Thanks very much, everyone.
Thank you. Thank you, Chair.
Shane.